Good morning. Thank you for joining us. My name is Cheryl Leary, and I am the Massachusetts Care Transition Lead from the New England Quality Innovation Network's Quality Improvement Organization. Thank you for joining us for today's webinar on using community big data to drive quality improvement. Before we get started, I'm going to quickly review a few housekeeping items. This call is going to be recorded for training purposes. The recorded presentation will be available within a few business days on our website. The phone lines will be on mute for the duration of the presentation. We will be taking questions at the end, and we will provide you with instructions at that time on how to ask your questions and get in the queue. Although the phone lines will be muted, we want you to actively participate in this session. You'll have an opportunity to weigh in via the chat function. I will be monitoring the chat and responding during the session. We'd love to learn more about your efforts and how we might best support you going forward. Continuing education credits will be provided for nurses who participate in this session. In order to receive credit, you will be asked to complete an online evaluation survey. Here are our learning objectives. By the end of the session, you'll be able to review the value of a driver diagram to help prioritize QI initiatives, identify approaches to determine if QI initiatives should be scaled, further evaluated, or abandoned, and then explore the optimal timing to bring technology into a QI process. So now it's time for you to weigh in. During virtual sessions, it's so important for us to connect with each other. So please use our chat feature. It's directly on your screen. Introduce yourself. Let us know how you use data or would like to use data in your QI efforts. I'm going to be monitoring your comments throughout the session. I'll weigh in and I'll share highlights at the end of this session when we open up the lines for discussion. So at this time, while everyone is chatting in and introducing yourselves, I'm going to introduce our presenter for today's session. Dr. Andrey Ostrovsky is a practicing physician and social entrepreneur who leads Care at Hand's executive management and strategic vision. He has led teams with the World Health Organization, United States Senate, and San Francisco Health Department toward health system strengthening through technology. Andrey has contributed to legislation at the city and national level to advance care delivery for vulnerable populations. And he serves on several boards and committees dedicated to interoperability standards, quality improvement, and innovation, including the National Quality Forum, a Federal Advisory Committee on Interoperability Standards, the ELTSS work groups with ONC, and the Commonwealth Fund Advisory Board for Breakthrough Opportunities Program, among others. He's a published researcher in public health informatics, quality improvement, healthcare innovation, social entrepreneurship, and care coordination. Andrey holds a medical doctorate and an undergraduate degree in chemistry and psychology, magna cum laude, and is a member of Phi Beta Kappa. Andrey completed his pediatrics residency training in the Boston Combined Residency Program at Boston Medical Center and Boston Children's Hospital, where he is a clinical instructor at Harvard Medical School. He is now an assistant professor of pediatrics at Children's National Medical Center. And at this time, I'm going to hand it over to Andrey. Thank you.
Thank you very much. I appreciate that. Can you hear me okay?
Yep, we can.
Excellent. Terrific. Thank you for passing the presenter role here. So thanks everyone for joining. I want to encourage and reiterate participation. If anyone has questions or comments, please feel free to enter your comments in the chat feature, and we'll pause and adjust them. The more dynamic, I think, the more productive the conversation will be. I will move briefly through the slides. We've got a lot of slides, and the first half of the slides is going to set some context, and the second half of the slides are what I think the most exciting part, which is real-life data from the field, particularly amongst community-based organizations and some of the innovative approaches to quality improvement. As the title points out, I'm going to be talking about blizzards, wildfires and riots, states of emergency and natural disasters have been unfortunate that they happen, but they have been interesting opportunities for us to use large data sets and use them in a unique way to drive quality improvement. And so those will be the three examples that I reference. And so without further ado, I'll jump right in and set a little bit of the context. Important disclosures. I'm the CEO of Charity N. I don't have any direct conflicts, but I think it is important to take everything I say with a grain of salt and keep in mind that the examples I will call upon are data examples that our technology has been able to extract from some of our partner organizations. In terms of the outline for today, I'll run through some of the important reimbursement drivers that are creating the environment that makes big data so important, and also what makes quality improvement so important. The second part we'll talk about are some of the, briefly address this, but it's important to mention the drivers of effective consumer engagement. And then the third, I'll speak to these actual examples around change strategies that use big data specifically in the community to drive quality improvement. So first, I'll start off with context that I think everyone is familiar with on this call, which is the fact that the way payment is happening for healthcare has changed significantly and continues to change significantly. This visual is meant to represent the top part, the continuum, one way to look at the continuum of care, particularly after the hospital setting, where the most acute care setting is on the far left, and the community and home setting is on the far right. And then there's everything in between, including acute rehab and long-term hospitals, skilled nursing facilities, assisted living, physician practice, etc. The arrows beneath this figure are meant to highlight how reimbursement happened before the Affordable Care Act, and frankly how it's still happening to the majority of the extent of reimbursement, which is that when people had an escalation of care, that often ended up having the person go to the hospital. And the lower figure is meant to represent how, after the Affordable Care Act, and increasingly, when someone has an escalation, the financial reimbursement incentivizes a less expensive, more appropriate setting of care delivery. And so it doesn't always have to be the hospital. It could be the physician's office, the patient-centered medical home. It could be skilled home health. It could be services being provided, such as long-term supports and services by community-based providers. And that shift in reimbursement towards a lower cost, more appropriate, better outcomes, that is what is a major driver of a lot of the things I'll discuss moving forward. The next thing I want to hone in on is a few specific programs just to highlight where we're seeing these drivers of innovation and quality improvement coming from. When the Affordable Care Act kicked off initially, everyone was talking about readmission penalties. Everyone is still very much feeling the readmission penalties, but more and more so the focus is on reimbursement mechanisms that have even more risk placed on the provider or on the payer. And those include programs like Medicare Freight Savings or Pioneer Accountable Care Organizations. Those include also bundled payments and a dual payment program through CMMI. And then, of course, the dual demonstration projects. There's many other mechanisms that introduce risk to providers, and these are just a few that I think are quite acutely felt by hospitals, physician practices, skilled home health, skilled nursing facilities. The reason this is all so important, and in terms of the directionality here, Secretary Burwell has pointed out that over 50% of Medicare spending will be tied to these alternative payment models by 2018. And that just solidifies how this is not a fleeting change. This is going to go, these drivers of reimbursement are only going to increase over time. I'm going to dig in on one particular program or one particular model of reimbursement, bundle payment, because this is a really exciting opportunity to look at where are costs coming from and then where can savings come from in delivering higher quality care. And what I'm highlighting here is a 30-day bundle, and so with the bundles, the BCPI program is 60 to 90-day bundles, but this 30-day example is pretty demonstrative of the point. We've worked predominantly with organizations that are engaged with non-surgical bundles, and so the DRG 192, 194, and 291, those three on the far right, are the ones that we have more experience with. What this figure highlights is the cost of providing care for these bundles, including COPD, pneumonia, or heart failure, when there is a readmission and when there is no readmission. And there is a major cost discrepancy here. So when organizations, let's say a post-acute care provider, is engaging in a bundle and they're deciding where do they put their resources, what kind of interventions do they want to put in place, interventions that prevent readmissions are a good and potentially very good investment of time and resource because you can avoid a lot of cost here. And another way to look at this is where are actual costs coming from other than just readmissions. And this is also a breakdown of spending during a 30-day bundle, and the comparison here is between a joint replacement, the DRG 470, diagnosis-related group, and then also for the DRG 291, for heart failure and shock. And if we focus on that right column, and we look at where is the cost variability, where are the costs coming from for a bundle, just under 44% are coming from the index admission. And then there's almost 15% of costs that are coming from physician interactions in the outpatient setting. In the yellow, the 17% of costs comes from post-acute care, so skilled nursing facilities, skilled home health. And then readmission costs contribute to about 17% on average of the bundle costs. And then there's other costs. Of note, this is not including Medicaid spending, which is a very important oversight of a lot of cost data, but I won't get into that right now. What I will get into is when we think about quality improvement initiatives, and when we think about tying quality improvement initiatives into the reimbursement reality, which is increasing risk and efforts to drive down avoidable spend. Here in the red box that I highlighted are two major opportunities to exert a change and focus quality improvement efforts on, one, reducing unnecessary costs in post-acute care, and also reducing unnecessary costs in terms of avoiding readmission. So that's about 34% of costs right there that can be significantly impacted by targeted quality improvement interventions, and in particular interventions that are happening out in the community. So this is why I wanted to highlight this clause. This is spending that is amenable to interventions that happen after someone gets discharged from the hospital. So this is some of the research we've published, which elaborates on contributors to cost, and in particular contributors to hospitalization risk. When we did an analysis of risk factors for hospitalization, and we reviewed intrinsic risk factors, meaning things like medical or surgical sequelae, functional decline, or mental health or behavioral health. The blue slice of the pie is when an episode of elevated risk was attributable to just the intrinsic risk factors. But when you look at the rest of the pie, there's a lot of contribution of extrinsic factors, and those include things like care coordination breakdowns, upstream health determinants like food insecurity, inability to get access to transportation, domestic violence, built environment. So those aspects fall under extrinsic risk factors, and here we're showing 38% of risk factors have an extrinsic contribution to them, and in particular the green slice is showing that care coordination breakdowns and intrinsic risk factors contribute to about 21% of these elevated risk episodes. And then care coordination breakdowns alone contribute to about 12% of these elevated risk episodes. What I'm to highlight here is, in the preceding slide, a lot of variability in cost drivers after people get discharged happen because people get readmitted or because of post-acute care spend. What we need to highlight here is that the interventions and quality improvement targeting doesn't necessarily just need to focus on a person's medical decline or medical management. There are care coordination breakdowns and extrinsic risk factors that quality improvement can focus on to drive down the cost of care. The next thing I'd like to highlight, and the slides are going to be publicly available so you can go into detail. I won't spend all the time reviewing each of these contributions to extrinsic risk factors, but we have outlined them here in detail. And I also briefly want to mention that it's not all about cost. Measuring quality isn't just measuring how many dollars were spent. There's so many other ways that need to be measured, and unfortunately the current approaches to measuring quality of care are somewhat lacking. And this is demonstrated by, if we look at currently available quality measures, in particular HEDIS, Hospital Outcome Survey, HOS, CAPS measures, and then the measures used by many managed care organizations, there's a real emphasis on medical care. And if we look at an organization I very highly respect, the National Quality Forum, and some of what they propose as emerging new measures, well, these still focus on highly medical issues. For example, here, 0495, the third one from the bottom, the median time from ED arrival to ED departure for admitted ED patients. That's good to measure that, but what about all of the quality that still needs to be measured out in the community? We identified 38% of risk factors in a Medicare fee-for-service population have an extrinsic component to them, and yet there's really not a lot of attention being paid to measuring quality in that setting. Fortunately, NQF has recognized that as a gap, and they have moved forward with embarking on creating a quality measurement framework for home and community-based services. This is just an example of the direction where that framework is going, and more information is available on the National Quality Forum website. I share this because it's a really exciting lens through which to look at quality improvement efforts that don't just myopically look at medical care, but rather take a more holistic approach at other determinants of care, and I think this is a very important domain of quality improvement and quality measurement. And this is what the draft framework looks like. Again, this information is available on the NQF website. In addition to quality measurement, there's also a parallel and very important body of work to streamline how quality improvement, quality measurement, and in general care is provided, which is around technology and interoperability. So folks are probably familiar with meaningful use 1 and 2 and meaningful use 3 that will happen down the road. But those are the interoperability standards associated with meaningful use almost entirely apply to medical providers. And here I'm trying to make the case that quality improvement can also, really should also look outside of the immediate medical environment. And so interoperability standards are now emerging to allow for standardized sharing of a care plan, not just between a hospital and a physician practice, but a hospital, physician practice, an area agency on aging, an aging and disability resource center, ADRC, and maybe a Meals on Wheels program as well. So home and community-based service providers. And this is a glimpse at what the draft long-term supports and services domains of a care plan are starting to look like. And for more information on this, folks can visit the ELTSS website, the Electronic Long-Term Supports and Services website that's being organized by the Office of National Coordinator and the SMI framework. And I can elaborate on that if needed. And I will pause after this slide to see if folks have any comments, but I'm trying to make the case here that there's opportunities for quality improvements outside of the immediate medical setting, that there are quality measurement opportunities that are emerging, that there are interoperability standards that are going to be supporting some of the quality measurement. And here is, if we look at this in back to a slightly myopic view of cost, one reason why looking to other sources of quality improvement, other sources of innovation in the community or even within the medical setting towards novel approaches to workforces, the current models of care coordination and care transitions really focus heavily on physician and nurse staff care coordination models. And in physician, this is a salary comparison of physician time, nurse time, and community navigator time. And I put this in the context of the chronic care management CPT code just for comparison purposes. So there's a reimbursement opportunity of about $42 for a minimum of 30 minutes of service provided a month for managing chronic care conditions for Medicare beneficiaries with multiple chronic conditions. Now, physician time, for half an hour physician time, is actually more expensive than the reimbursement for the chronic care management. Whereas the nurse time is substantially less expensive. And then furthermore, if you look at the community liaison, navigator, or similarly, let's say office secretary of physician's practice, the cost of that time is significantly lower. Now, the scopes of practice are fundamentally different. But there is an opportunity to better tap into the existing workforces that are already in place. The challenge is, of course, how do we do that in a safe way? I'll pause here. Any folks have any thoughts, questions, comments they'd like to throw into the chat here? And I see a colleague here posted a question about the 38% of risk factors being extrinsic, and whether that surprised anyone. Any folks have is that surprising to anyone, or any comments about the opportunities for looking at other workforces in terms of quality improvement interventions? All right, if any comments do come in, I'll make sure to address them, but we'll move on. So I want to show highlight a very quick example of, specifically within care transitions, of looking at quality improvement interventions through the lens of a different type of workforce. So not necessarily the doctor and the nurse, but perhaps a direct care workforce or a non-medical workforce. And the example I want to highlight here is in terms of a readmission penalty. And again, readmission penalties exist, but there's so many other drivers of care. But readmission penalties are a little easier to do the math. But if we were to overgeneralize and actually amortize the penalties for readmissions, and look at what does a readmission cost in general because of the penalties, it's about $200 in terms of a slap on the wrist to a hospital if someone gets readmitted within 30 days, and they're readmitted because one of the diagnoses that are amenable to the readmission penalties. So when a hospital or health system or a population health manager is deciding to do an intervention to reduce readmissions, the reality is that if the intervention costs more than $200, then there will be a net loss of money. Again, oversimplifying here. Whereas if the intervention costs less than $200, there will be a net savings. Just focus specifically on this readmission penalty. And this is really just meant to be by a very generalized example. The exact numbers are not precise. What I want to highlight here is some of the leading care transitions models and their cost. So guided care is a very well-established model that showed impressive outcomes in terms of reduced readmissions. This is a model that uses clinicians, nurses in particular, and the cost of that model is $1,700 per consumer per year. If we look at another model, the GROSS model, this is a model where it's a nurse partnered with a social worker, $1,400 per consumer per year. The transitional care model, led by Mary Naylor, per consumer per year, and that's a focus on nurses and advanced practice nurses, NPs as well. So then if we get into one of the most ubiquitously used care transition models, or care transition intervention, led by Eric Kramer and his colleagues, some of their numbers showed that the model costs about just under $200 per consumer per year. But, and this is to their credit, in the limitations of their publications, they acknowledge they did not do an econometric analysis of the true cost of the intervention. And so this is likely a substantial underestimate of the cost of this intervention. And from what I've seen, particularly from the community-based care transition program and the reimbursement for those types of transitions, we're talking in the order of $350 to $400 per consumer. Now, I'm comparing apples and oranges here to some extent because the readmission penalty I described as $200 per transition a year. I'm talking about cost per year. So the costs really depend on the population and their likelihood to readmit. But I just want to give some numbers for comparison purposes. And the real point of what I'm trying to bring up here is when a clinician is the intervening agent, if you will, the coach, here are some of the activities that they're doing: care coordination, care management, medication reconciliation, education red flags, and follow-up appointments. And this is really echoing the care transition intervention. However, when we split out potentially the role of the RN and the coach, and perhaps the coach is filled not by an RN skill set, but by another skill set that is also less expensive worker, there's an opportunity to still perform many of the same functions, but perhaps at a substantially lower cost, with the added benefit of a health coach being able to come from the same community, have the same educational level, the same language, and same cultural background as the consumer that they're serving. Meanwhile, the nurse can still be involved very much so in doing the nurse-specific activities: care management, communication with physicians, triage, determining if the consumer is sick or not sick. So really, a skill set that is exclusive to an RN level of provider or higher. And the interesting opportunity here, of course, is that when the RN isn't the predominant touch point, but rather serving a supervisory or adjunct role, but the predominant touch point is actually a less expensive workforce, like a coach that is, let's say, a former personal care attendant, or as highly trained actually as a social worker, but not medical, and having a lower level of cost. What we've seen is for about 800 transitioning patients a month, those patients have been serviced by 20 of these health coaches, supervised by a single RN. And so the cost becomes quite different in terms of the traditional transitions. So I want to briefly, this information is available online, but this is one approach to utilizing that type of workforce, a non-medical workforce, supervised by an RN, and I won't spend too much time on this. I will jump in here into the engagement piece. So I've made the case there may be a financial differential in the type of workforce being focused on, but the quality of interaction is also fundamentally different, and this comes down to engagement. So consumer engagement is important because if engagement doesn't happen with the consumer, then we can't really exert an intervention. If we can't exert an intervention, we can't prevent acute care spending. And then also without engagement, this particular from the perspective of the health plan, very hard to enroll members when you can reach them in the first place. And so that also comes down to a financial case where if you can't enroll people, then the health plan just can't get paid. But this is actually a slide that I think is probably the most important thing to point out. Where do consumers spend their time? And I emphasize consumer or person as opposed to patient. So we may all be patients at one point in time, some of us for longer periods of time than others. But we are always people, and we're always humans, if you will, in the community ideally. So when you think about where consumers spend the majority of their time is spent out in the community and the home. And so when interventions are being put in place, those interventions, if they're really going to engage the consumer, should be focused on meeting the consumer where they are, which is in the home and in the community. And so home and community-based services lend themselves to reach consumers much better because that's where they're deployed, in the home and in the community, whereas medical services tend to be deployed in the hospital setting, in the physician setting, or in a skilled setting, which is the minority of time that a person spends. So it's purely just meeting people where they are in terms of quality improvement interventions. I want to take a quick pause here. I see there's a question, comment was posed here. And I see Cheryl had a question about pharmacy students being used to support medication management. So that's an interesting point. Although the organizations we've partnered with have not used pharmacy students, Elder Services of Merrimack Valley, which is an area agency on aging in Massachusetts, they have very successfully used nursing students as part of their care to admissions program, and they've students are a very cost-effective labor force, of course, if they're supervised effectively, which they were. And it is a great learning point. Actually, four of the students, nursing students there, were actually part of a research study that we did where they were research assistants and co-authors on an important paper. So I think the use of students and pharmacy students is really an interesting question. Thank you for that question. One other piece about engagement, Robert Johnson Foundation did a survey of 1,000 physicians and asked them a few really interesting questions. And as a physician myself, I can sympathize with this. 85% of physicians said that unmet social needs directly lead to worse health, which is kind of like a no-brainer in my mind, but I guess someone had to quantify it, which is good. Then another 85% say social needs are as important to address as medical conditions. Also, I think kind of good to quantify what is probably common sense. But this last piece, I think, is really telling, and probably not something that physicians are quite as open about admitting. 80% of physicians were not confident in their ability to address social needs. I think that's really important, and if we put this into the practical workflow or time constraints on a physician, physicians are very much pressed for time, and not only is there often not enough time to address what is so essential, which is social needs, but even the skill set required is oftentimes not there. And fortunately, we have our social work colleagues, case management colleagues to address those needs, but it's clear doctors cannot do it all, and frankly, we don't have the time to do it all. So this gets to the third point I want to highlight, which is, okay, we identify potential cost differential in different types of interventions, and that may align with the reimbursement realities that are happening now. But then there's also consumer engagement piece where meeting people where they are is so important to driving quality improvement initiatives. And I want to identify how data comes into the picture, in particular big data. And the example I want to give here is this figure. This figure is meant to represent, over time, a consumer's risk for hospitalization. There is really good research out there on using claims data and EHR data to predict hospitalization risk. And this is what the blue dots are meant to represent. The challenge, of course, is between the doctor visits and between the hospitalizations, between the time points when claims are generated, there's a bit of a blind spot. There's an important blind spot because this is where there are opportunities to pick up a consumer maybe escalating in hospitalization risk, intervene, and hopefully prevent them from going to the hospital. And a major hypothesis that my colleagues and I have had has been, well, what if we utilize the assets in the community, the workforce that is already interacting with the consumers between the doctor visits, to perhaps somehow use their insights to predict hospitalization risk. And this is effectively what we've done with our research and our technology. We have proven that we can predict hospitalization risk using the observations of non-medical staff. This is a brief schematic of how it works. I'll let folks go into details them as needed, but essentially there are already staff interacting with consumers either in person or telephonically on a regular basis between the doctor visits. The staff can document a 2 to 3 minute survey of yes/no questions, and this is where our research science comes into play, and I can elaborate on that in the Q&A if needed. About 1 in 5 of those surveys will identify elevated risk for hospitalization, and then that elevated risk for hospitalization will be communicated to an RN on the care team, and the RN has the scope of practice to be able to triage that information, communicate back to the non-medical staff, usually just call them right away, and then have a discussion about what is the most appropriate care coordination or care management that needs to happen to ensure that consumers stay safe, and at the same time, doesn't need to go to the most acute, most expensive care setting. Now, this is the delivery model that most of our partner organizations are using. Some of our colleagues, particularly, again, folks from our own backyard here in Massachusetts, data we've published with them, specifically with AHRQ, identified that for a Medicare fee-for-service population, when comparing before and after introduction of a community-based transition program, a program that happened to be using our technology, there was a reduction in 30-day readmissions by almost 40%. And when we look at specifically acute care spending relative to the cost of the intervention, including technology, which is relatively minimal, but also including the increased cost of care coordination. Remember, when data is coming in, someone has to triage their data. That's increased cost. So when all of those costs are incorporated, there was still a significant net savings. And then this is, ROI really is so important to identify. A separate study we did, and I apologize, I don't have the references down here. I think I have the references at the end. We've been able to identify that non-medical staff using this technology are able to predict or contribute to prediction of hospitalization risk 30 to 120 days out. So that's a very important opportunity for intervening and keeping people out of the hospital. Again, here's the reference to the data identified in terms of the savings, and here's some of the data in terms of the risk model that we've published on in the reference here below. I see a question here. Thank you for that question, Stefan. Is the cost avoidance showing all claims? Excellent point. We actually have a study that is specifically using claims data, Medicare A, and that study is yet to be published. But the data that we're referencing here for the AHRQ study actually used not claims, so it's a major limitation. What we did use was the hospital administrative data from the 6 referring hospitals in the geography of the AAA that where the data came from. And what we identified was about 10 to 12% of patients being discharged from those 6 hospitals. There's 10 to 12% patient leak. In other words, they went downtown, to Boston, or maybe they went to New Hampshire for readmission. And so that's a major limitation of this data. Having said that, we did capture the majority of readmissions, and so that's why we can perhaps draw some association between the intervention and the cost reduction or cost avoidance. But to your point about claims, this is actually not using claims data, but rather EHR data. And absolutely more research is needed to really tease out cause effect. So I appreciate that question. Thank you. And please, if any other questions arise around that and the methodology, please let me know. What I want to kind of focus on now, and before we go into the Q&A, is to spend a little time on 3 examples of bread and butter quality improvement. So we've shown you that there are technological innovations that can help transition. There are innovations in the community that can take a different perspective on transitions, particularly around the workforce. The workforce is not entirely driven by nurses, but rather a workforce that's non-nurse supervised by a handful of nurses. Here are 3 examples where we have, this example happens to be actually from Massachusetts, but we have examples also from the state of Washington as well as the state of Maryland, where data from this technology held to bring to the attention of the care team information that they may not have identified otherwise, but also the technology was able to drive quality improvement efforts in a targeted way. The first example I'm going to highlight is the blizzards from last year. And for anyone in New England, which I'm assuming most of the folks on the call are in the New England area, there was a lot of snow, and I just moved from Boston down to DC, so I spent the winter riding my bicycle to and from the hospital, and it was rough. But not as rough as for the consumers, the elderly consumers or patients being discharged from hospitals. So here are the snow totals from January to beginning of February, and as you can see, this is where Gino started the onslaught, followed by several other blizzards, and there was a lot of snow. That's the point of what I'm showing here. Now, here's data from the Transitions Program being provided by Elder Services in Merrimack Valley, and I appreciate them letting me share this data because it's not all very rosy data. It's actually showing a poor performance in the following sense. The red line here is reflecting the time to first visit after discharge. The first visit being an in-person visit by one of the transition coaches from Elder Services in Merrimack Valley. And what we can see here is the time to first visit went from a best practice 2 to 3 days, all the way up to 8 days. 8 days from when the elderly individual is discharged from the hospital until when they're seen in the home. 8 days when they may not have someone to review their medications to make sure they know what medications to take. 8 days to even identify that the elderly individual has no way of getting transportation through the blizzard to pick up their medication. This is also an 8-day gap of having someone, a health coach, come to an elderly individual's home and come to find that after their hospital stay, there may not be any food in their fridge to eat. So if it was, for example, a consumer with heart failure who was told, you need to eat a low-sodium diet, but the only food available is the canned food with high sodium in the cupboard when there's no food in the fridge because, again, there's a blizzard outside. 8 days until someone could come in and identify that, et cetera, et cetera. So there's a big gap in terms of what should have been happening and what was actually happening, and not the fault of Merrimack Valley, but rather there's an active blizzard, and what we came to find out is actually there was 4 days when the entire office was doing a virtual office because no one could come into work. So when we identified this data, and we have pretty regular check-ins with all of our partner organizations. Every 2 weeks, our chief quality and nursing officer checks in with their counterpart at one of our customer sites, and we review the data. And so this was one of the reviews, and we said, oh my goodness, it's time to filter this just went to 8 days, which is a little bit ironic because we could just look outside and see this massive snow, but it took a dashboard for us to connect the dots that, wait a minute, maybe we should be targeting some QI efforts on making sure consumers are getting timely follow-up visits. So Merrimack Valley was very, very timely, and to their credit, they don't, like most other community organizations, they don't get paid extra to do better work, but to their credit, they actually invested their own resources to do a PDSA. Their first PDSA focused on trying to make sure that over the weekend when consumers were being discharged, to make sure that they have extra coverage in terms of coach staffing to do the follow-up visit. And so they invested in extra hours. They paid for more time for more coaches to do in-person visits on the weekend. And what they found was over the subsequent 2 weeks, there really wasn't much of a decrease in the time to first visit. There was a bit of a decrease, but the blizzards kept happening, blizzard after blizzard. And they only got down to, 222. They were at about 7 days until the first visit after discharge. And so we regrouped. We were checking in, again, pretty routinely. And what they were able to do then is say, okay, extra weekend coverage does not appear to move the needle over the past few weeks. There was no special cause. We didn't have well, frankly, the data points here on a weekly basis, but we can filter on a daily basis. We did not have a convenient 6 to 8 points under the preceding average that would identify a special cause and hence make us think we're moving the needle in the right direction. There was really no movement. So they implemented a different PDSA. So the next PDSA was focusing on the same theme. The theme was staffing. Maybe if we can get more staff to do follow-up in home visits, we would be able to decrease the time from discharge to first visit. And so the next PDSA focused not on weekends, but a greater investment. They actually kept the weekend coverage and also added evening coverage. So after the workday ended, usually it's a 9 to 5 program. People work 9 to 5. People go home after 5. Here they invested in after 5 p.m., helping consumers who are recently discharged actually be seen from the, I believe it's 5 to 9 p.m. time frame. And look what happened then. So I need to point out, the blizzards kept happening. So this wasn't that there was just less snow. There was actually more snow into March. But watch what happens to the red line after the second PDSA was introduced. So if it's this PDSA was introduced, then the time to first visit drastically decreased. Now, there may be a residual effect from the first PDSA. So this isn't, again, there's no cause effect here that we can go. This is QI. But we did identify that they were bending the curve in terms of the time to first visit, and so they continued that intervention until the blizzards relented. And from my perspective, it's very simple on the surface, but when you think about an organization justifying investing their own resources to improve quality of care and using data to drive those resources, I think that was pretty impressive. Any questions about this one so far before I move on to Washington? Feel free to chime in on the chat. I'll take a moment and see if anyone has any comments or questions. And if they just pop up, I'll make sure to address them. We'll move on to the next example. Briefly, time check. How are we doing on time? Do we have another 7 minutes or so? And then we'll jump to the Q&A. Does that sound okay?
That sounds great. Thanks, Andrey.
Perfect, thanks. The next example is in the state of Washington much more recently. So state of Washington and Oregon, there were substantial wildfires going on. We have a partner organization, Aging and Long-Term Care of Eastern Washington, also an area agency of aging, similar to Elder Services of Mammoth Valley. They have a care transition program in place. And we identified something, it's a little bit concerning. So the heat map is showing here the fires up in the upper west. And on the bottom right is the heat map around Spokane, Washington, which is where most of the consumers that were being served. And we identified, I think I should have spoken in the next slide, 65, it was actually 55 consumers that were at increased risk for hospitalization that previously were not amongst the highest risk consumers. It's important to note these are not real names. They identified that these are made-up names, but this is what the information looked like for the team at Aging and Long-Term Care of Eastern Washington. What they found was, here's the highest risk consumers, and what we found was a little bit interesting. First, what people are interested in, these are new people. They're not the typical frequent flyers and not the typical highest risk consumers. Those are new names. When we found new names, when we did our usual biweekly check-in with Aging and Long-Term Care of Eastern Washington, we started digging into a root cause and trying to think, why is it that there's just brand new people at increased risk? So again, it took a dashboard for us to realize there was a natural disaster happening, but we found some commonality. So again, I apologize, it's not 65, it's 55 patients that were identified. We found that many of them had respiratory illness as one of the major active issues with COPD. Many of them had inhaler use as one of their medications, and also around DME, when we look at that domain, there's many of them an O2 requirement. And so we put those pieces together, and some very bright intern in the room said, hey, there's smoke in Spokane, and then we said, oh, wow, like, this is why our dashboard is saying it. So we quickly connected the dots that the downwind effects of the smoke from the wildfires may be putting people at risk. And in other words, they were triggering increased points on the surveys being performed by the non-medical staff doing transitions out in the community. So we provided some guidance and recommendations and worked in concert with the nurse leadership at Aging and Long-Term Care in Washington, and we provided this kind of hit list, if you will, of 55 highest risk consumers. And outside of the usual care transition program, the staff at AltQ reached out to those consumers and basically did a quick assessment to see what, if anything, was new, addressable, things that could be helped around care coordination, perhaps care management. And 23 of those folks ended up receiving a targeted intervention as a specific response to that check-in call. And the interventions were things as simple as here's a mask to wear to help with some of the filtering of the air. And some of the interventions include relocation, like going to a family member's home that wasn't in Spokane. And, some were pretty drastic. Unfortunately, there were some consumers that just couldn't be reached, and we're still figuring out where they are and what's happening there. And we did notify the public health authorities locally that local people are being discharged from the hospital and they're going to a downwind area of the forest fires, think twice, especially if it's an respiratory illness, etc., because we may be sending these consumers out into an unsafe setting. And it may not be exactly top of mind of a busy discharge planner in a hospital. So their QI focused on initially like the telephonic outreach, and then focused on, well, when you do a telephonic outreach, what are we going to do with people that don't respond? And so the next round, and this is still ongoing. Beginning of August is when the fire started up. So they're still undergoing a series of PDSAs, trying to tweak on how do we actually find the people and address the concerns of the folks that they couldn't reach out to initially. So again, another example where you have already a very progressive, highly competent transitions program in the community, but they're using data in an intelligent way to not just shotgun approach that target everyone, but go for a specific subset of people for a very targeted quality improvement intervention. Got one more example, and jump right into that, and folks, please feel free to chime in with comments or questions. Next example is where I'm from, Baltimore. So unfortunately, Baltimore, West Baltimore in particular, there's been some really sad attention to Baltimore around the riots in the wake of the death of an individual in police custody. And so that basically just unroofed a lot of lingering socioeconomic, sociologic issues in the city. What is unfortunate and interesting is if you look at the area where the riots were happening, I've got a graph here showing life expectancy around different zip codes in Baltimore. But the dark red is really disconcerting because this is really areas where rioting happened. Also the areas where life expectancy is literally a decade lower than the rest of the city average and about 15 years lower than the U.S. average. So there's populations at massive risk, not just inequity in many regards, but specifically around mortality. And so fortunately, there's some really exciting work being done in West Baltimore and specifically around transitions from hospitals in the West Baltimore area. And those transitions are being supported by an organization called the Coordinating Center. So like Elder Sisters of Merrimack Valley, Massachusetts, and Aging Long-Term Care East Washington, the Coordinating Center is traditionally a provider of home and community-based services, but they are quite innovative and offering a transition service. Again, largely driven by non-medical staff doing the touch points with consumers in the community, supervised and working in concert with nursing staff to make sure nothing is falling through the cracks. And so this data is really interesting to me because what it shows is, and this is a longer time frame that's actually CMS data, prior to the intervention, prior to the coordinating center offering their transitions program, the readmission rates in the West Baltimore hospitals were pretty high, and there's a lot of variables contributing to that. If you look at the blue bars, that is the readmission rates from February 2014 to January 2015. So this is as the intervention was introduced, the care transition program was introduced. The orange bars is readmission data from February 2015 till April 2015, and the major intervention, the major QI initiative by this already progressive, highly competent community-based transition program was use of this predictive analytics and early detection platform. And what we found, and again, there's no cause effect here. This is QI data, and this is a very long time frame, but it is an interesting trend. The readmission rates for an already impressive reduction of readmissions went down further by another 5 to 20%. So not only are we engaging consumers more, not only are we doing it in a more cost-effective way because of the nature of the workforce being used, not doctors other than community liaisons, but now we're taking it another notch further and using targeted early detection of risk in the hands of these non-medical workers. Right? I think that's pretty impressive. And ultimately, when we come to scalability, the coordinating center was able to use publicly available Medicaid and Medicare data to do some projections on cost savings. And so for overall, and this isn't just the intervention that tapped into our technology, this is overall, they were able to serve over 3,000 consumers transitioning. They were able to achieve, the cost of the interventions were over $1 million. But when you look at the rehospitalization avoided, it totaled to almost $3.5 million in savings. So a pretty impressive return on investment of almost 190%. And that to me is kind of the punchline here, that community-based interventions, specifically those that effectively target their QI interventions, have a really interesting opportunity to address this shifting landscape in reimbursement and focus on the AAA, improve outcomes, decrease cost, improve patient experience. So those are the things I wanted to share with everyone, and I always finish with this. This is my grandma and my sister. My grandmother passed away because a home care worker did not report, not because a home care worker knew that she fell down, that they did not know she broke her hip. That information never reported until she ended up going to the hospital because of infected hip, ended up passing away because of a ventilator-associated pneumonia. And so that home care worker was actually a dear friend of ours. It's a home care worker we continue to love to this day, and it was not her fault. It's the challenge was, of course, the systems around her, and the fact that she didn't know that she had to report it. And so when we look at quality improvement, I think we need to always think about what are the workforces that we can be looking to target our quality improvement efforts, and I think the non-medical workforce is just such a ripe area to target. So with that, I welcome any questions or comments, and thank everyone for their attention. Thank you.
Thank you so much, Andrey. That was a great presentation. We only have about 2 minutes left. I'm just going to ask Mary to tell us how to get in the queue. We probably only have time for one to possibly 2 questions. So Mary, if you could do that.
Sure, ladies and gentlemen, if you'd like to ask a question, please press star 1. I will open your line one at a time so that you may ask your question. When your line is red, you'll hear a prompt asking you to proceed with your question. If you'd like to ask us a question, go ahead and press star 1 now.
Thank you, Mary. So you gave us some great examples regarding the use of non-medical staff and providers in approaching quality improvement and partnering with home and community-based services. And I thank you for that. Those were very interesting and informative. We'd like to know right now if there are any questions in the queue.
I have no questions at this time.
Okay. We have had some chat. We have had some patient advisory council members chat in. Thank you so much. That's a great non-medical staff. That is an opportunity for use in QI. We've had home health aides and nursing homes that are interested in being included in bundles in the chat. So we do have some interesting ideas and opportunities out there. I thank you, Andrey, very much for giving us this insight and new information that we can go and use and talk to our teams about how we might be able to target our interventions by using data. And I appreciate everyone for listening to us this day. You will be receiving an evaluation that will come in the mail within the next day. Please fill out that evaluation, and if you are a nurse who needs CEU credit, can you please fill that evaluation out so you'll get your credit notification.
Great. Thanks, Andrey. This is Lynn Chase, and I just wanted to thank you for your time and for the participants on the line. If you did have a question but didn't have an opportunity to ask, feel free to submit those either to the state lead or to the website. The slides from today will be posted on our website, healthcarefornewengland.org. Thanks so much, everybody, and have a fantastic day.
Thank you.